Hello, I'm Martha Lacy. I'm a professor of medicine at the Mayo Clinic in Rochester, Minnesota. I'm here at the ASH meeting presenting the results of our study using Pomalidomide, Bortezomib, and Dexamethasone PVD for patients with relapsed lenalidomide refractory multiple myeloma. The combination of pomalidomide and dexamethasone has been extensively studied in lenalidomide refractory patients and has response rates of about 30%. The strategy of combining IMiDs with proteasome inhibitors is also well established in myeloma. The results of the first PVD trial were presented last year at ASH. It was an MM005 trial that utilized twice-weekly Bortezomib and 4 days a week of dexamethasone in combination with pomalidomide. Our study, in contrast, uses the standard pomalidomide dexamethasone schema with dex once a week and pomalidomide continuously, and we added once weekly Bortezomib to it. We were hoping that by reducing the dose intensity of both the dexamethasone and the Bortezomib that we could retain the efficacy of the regimen but make it more tolerable to patients and more convenient to administer. The major eligibility criteria were relapsed myeloma with 1 to 4 prior regimens. Patients had to be lenalidomide refractory. They could have had prior Bortezomib, but they could not have been Bortezomib refractory. They had to have adequate bone marrow reserve as evidenced by good blood counts. They had to have adequate organ function and a good performance status. We accrued a total of 50 patients. The first 9 were in the phase 1 portion. So the study we described here included the MTD in the phase 1 portion as well as the 41 patients that were included in the phase 2 portion. Treatment consisted of pomalidomide 4 milligrams orally days 1 through 21 of a 28-day cycle with Bortezomib 1.3 milligrams per meter squared, either subcutaneous or intravenous once a week, and dexamethasone 40 milligrams orally once a week. The major toxicity was neutropenia, with grade 3 neutropenia seen in 68% of the patients. Severe thrombocytopenia and anemia were quite rare, with only about 2% of patients having severe anemia or thrombocytopenia. The non-hematologic toxicities were mild, with very little grade 3 or higher, less than 5%. The major non-hematologic toxicities were mild GI toxicity, peripheral neuropathy, and fatigue. Confirmed responses of PR or better were seen in 85% of our patients, including 45% with VGPR or better. Results were durable, with a median progression-free survival of 10.8 months and a median duration of response of 13.8 months. Overall, we found that the PVD was a very well tolerated regimen. It's active with responses of 85% confirmed responses, PR or better, in this lenalidomide refractory population, and we found it to be a very tolerable regimen with toxicities consisting mainly of mild cytopenias.